tell them that it's time. And as usual, we would always start on time. So since we've started, do prompt them. Those who weren't able to sign up using our link that was shared, please, they can always join us on our YouTube channel, which is the Parent Professional Connect. If you've already subscribed to it, then you would be getting the notification that it's time. Join in the live stream. And yes, who else would help us get to understand what refractive error is? And yes, since you know that admission pediatrics and admission clinic, we have diverse subsects of the institution. We have the part of the optical. So for today, our optometrist, who is in the person of Dr. David Sam, is going to help us understand what refractive error is. And one may wonder who he is. He is actually someone who is an optometrist, as I have earlier mentioned, and he has experience in eye examination, eye procedures, in terms of visual acuity, in terms of the I always say that their words, I need to take my time to pronounce it. Um, of the all of that. The bioscopy examination and performing refractions, kerathermetry, and all those other big names they have in their field. For today, he's just going to help us understand what refractive errors are. What is it? How do we get to identify it? What are some of the things or types that we may have? And yes, get all your questions ready for him. If you feel you may forget something, please do type it in that chat box so that you do not forget it. As he explains something, if you would want us to come back to it, just leave us a comment so that we get to have it. So whether you are listening to us here on Zoom or on our YouTube channel, whichever page you are on, please do leave your questions there and we would get to respond to them. So I wouldn't want to take much of the time so that Dr. Sam can have the time to explain things to us very well. And as I always say, you have a free consultation currently. So please do tell a friend to tell a friend that it is time. And it's time for us to get to understand what refractive errors are and how best we can aid ourselves. So, Dr. Davis Sam, please, the floor is yours.
Good evening once again, and thank you, Ms. Aida. So, as I said, as was introduced, my name is Dr. David Sam, and I'm going to be taking you guys through refractive error this evening. So, if Ms. Aida can project the slide for us, then we'll just start from there.
Yes, please. Okay. I hope you can see the slide. Is it visible?
Yes, please, I can see it.
All right. So I think we can go.
Okay, so when we say a refractive error, okay, it's simply a visual problem where it makes things harder for you to see. So what do you mean by that? It means when you are looking at something afar, the way you're supposed to see it, you're not able to see it as a normal person will see it. Let's use that word. So if you go to the introduction. Okay. So as it says, a refractive error occurs when the shape of the eye prevents light from focusing precisely on the retina. So when that happens, it's either the eyeball is too long or it has too much power. So for every eyeball, there's an approximate length, which we call the axial length, is supposed to have. With people with refractive error, this length might be either too long or too short. And in terms of the power, there's a specific power you're supposed to hold, each eye is supposed to hold. With people with refractive error, either their power is too high or too little. So when that happens, light from outside, let's say we are observing an image or observing someone, that light from the person which is supposed to fall on the retina does not get to the retina. Okay. So it gives them blurry vision. It can give them so when it comes to the blurry vision, people will strain to see things clearly, which will lead to a lot of headaches and a lot of eye strain, which sometimes people can feel a little bit teary eyes, dryness. They are all symptoms associated with prolonged strain of the eye. So there are four main types of refractive error. Okay, I'm sure most of us know them. We have the nearsightedness we call myopia, farsightedness we call hyperopia, astigmatism, and presbyopia. Okay, so we'll be taking each one at a time. Then we'll understand how they come about and what we can do to prevent, or I won't say prevent, but what we can do to make our situation a little bit better. Okay. So for the most commonest refractive error we have in the world in general is myopia. And with the changes of the time, myopia has become more prevalent, especially in the kids. Okay, so studies have found that children who do a lot of screen time in their early childhood, let's say from birth to like 12 years, they're always focusing on books, they're using their phones, using their tablets, watching TV at a very close distance. These children tend to develop myopia more than children who go outside to play. That doesn't mean that if it's encourage your child to go outside to play a lot, they wouldn't develop myopia. There's also a genetic factor with myopia where, let's say, two parents, one has myopia. There's a tendency of the child also developing myopia. So when it comes to myopia, there's two things involved. Either the eye has too much power or the eyeball is too long. So when light from an object is viewed, that light doesn't get to the retina. It falls in front of the retina. So there's a gel-like substance between the lens and the retina. I think the last time we did our parents meeting, I gave a short introduction about the eye, the parts, and all. I should have put that slide again, but you just bear with me. So the light will fall in the gel-like substance. So it's like trying to look at something through water. It's not that clear. It's a little bit blurred and distorted. So that's how a myope will see things. So afar, everything looks blurred and distorted. But when they bring it close to them, it looks very, 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 very sharp. Okay. So for those kind of people, we give them what we call a minus lens. Okay. So what this minus lens does is that it reduces the amount of power they already have. So in that sense, let's say the total power an eye needs is, let's say, 60. The myope might have, let's say, 65 or 67. In that case, the minus lens comes into play. It reduces the power to what a normal person will need. So the image will fall right on the retina. That will help the person to see things much, much clearly. So assuming your child has myopia, what do you expect to see? So one, they might complain that when they're in class, they can't see from the blackboard. Okay, and I also want to put it across that it's not always that they can't see. Sometimes to the lighting in the classroom also play a role. With these kind of whiteboards we have, when they're using the bright lights in the class, it tends to cause a slight distortion of the on the board. But you as a parent, what would you expect to see? Let's say you're watching the television with your child, then they tend to get very, very, very close to the TV set. Then that should prompt you that they might not be seeing things as well as a normal person is supposed to see. To the child, to their mind, they are seeing perfectly fine. That's how everybody is seeing. So they wouldn't know that they have a problem which needs to be addressed. So you also have to be a little bit vigilant to know and see these signs so that you can easily bring the child in for us to check. Okay, so next slide, please. Can we move to the myopia slide so I can show them the light I was talking about? That's the third slide. Hello? Okay, thank you. So as you can see, what I was talking about, where if you look at the diagram we produced there, then assume the light blue shade is the lens. So when the light comes from outside, passes through the lens, it doesn't hit the yellow part, which we are assuming is the retina. It falls right in front there. So with this, like I said, when they come into our office for children, the test we normally do, for let's say from the ages of 0 to 12 years, this is where we know that there's a critical development of the child's eye, especially when it comes to vision. So within this critical period, this is when the eye assumes most of its refractive error. Okay. So during that period is a very critical period where we can make adjustments, where we can make changes to the eye to at least help the eye achieve a bit of refractive error which can be tolerated. So when they come, we have a special test for them, which involves the use of ocular dilators. Okay, so when we say that there are drops we install in the eye to relax the eye. So in that sense, there's no force training from the child. So we can get the actual error the child has. Then we can give glasses to address their actual refractive error. Okay. So please can we move to the next slide? So when it comes to hyperopia or farsightedness, it's rather the opposite effect. So for them, they do not have enough power and their eyeball is too short. So when light comes from an object, instead of falling on the retina, it falls behind the retina. But the one thing about hyperopia is that they can make up for the power they do not have by making use of their accommodative process. Okay. So when we say accommodative process, it's just the ability of the eye to change its shape or to increase its power to look at things when it's close to them. So you using your phone right now, your accommodation is engaged in order to make what you're seeing on the phone much, much clearer for you. So the hyperope will make use of this ability to move the thing, to move the image straight onto the retina. Okay. But here is the case. When they do this for a very long time, they start experiencing a lot of headaches. Okay, so for them, one of their major signs is headache, a lot of headaches. So they also can't sustain near work for a very long time. So if you have a child who after 30 minutes of reading, they say they cannot read again, they're not feeling comfortable, they have to go and do something else. It's not their fault. It might be that they have hyperopia, which has not been addressed. And with hyperopia, depending on the severity of it, there can be either blurry vision or no blurry vision. Okay, so assuming my hyperopia is let's say around +1, +150, +2, I can still see things around clearly by making use of my accommodative factor. But the higher I go, the more it becomes blur and I can't make up for it with my accommodative factor. So with such case, the same test we do the psychoplegic test, which I said we use the ocular dilators. For them, it's very, very, very effective compared to the myope. The myope, regardless if you relax accommodation, the error is still going to be the same value with just slight variation. But with the hyperope, it gives us the full value without the accommodation being intact, since these drugs relax the accommodative process. So we've come to the third one, which we call astigmatism. A very big name, but is very, very simple. So if you assume the eye the part that helps bend the light, which is the cornea, has a round ball, let's say as round as a ping ball. Ping ball. This is a tennis ball. Tennis ball is much easier. I can't pronounce the ping ball that way. I can't pronounce it. So let's assume the corner is as round as a tennis ball or an orange. You see, when you look at it, when you draw a cross on the tennis ball, the horizontal and the vertical line are always going to be equal. Okay. But when we take something like the American football or an egg, it's not, when you compare the horizontal and the vertical, they are always not going to be equal. There's going to be a slight variation between the horizontal side and the vertical side. Okay. So that variation is what we have in astigmatism. That means the eye's meridial power has two different powers. Okay. So one might have a slightly higher power than the other. So in that sense, the light is not falling on the retina. We can have one falling in front and one on the retina. We can have one falling at the back of the retina and one on the retina, or we can have one in front or at the back. Okay. So with these people, when they look at light, they start to see it's coming like a streak of light, a thin streak of light emanating from the primary source, which is the bulb. Okay. Or when they are reading, when you are doing the visual acuity test, I'm sure you've visited an eye clinic, they will tell you cover your eye, next read. They might be confusing very close letters. Like they might see a Z as an X, a C as an O. So those letters that look very similar, they might confuse the two. It's not that they cannot see, it's just because of this astigmatism. That's why they are not be able to see that slight variation between the letters. Okay. So for such people, we give them lenses. Their lenses will have a cylindrical component. Okay, so it will have one for the sphere, which will address the major power, and the one that will address the cylinder, which will address the minor power. So for them, if you pick up their glasses and wear it, you will definitely not feel comfortable. It will look very distorted because for them, it's specially made to address a situation they are having. Okay, so sometimes this, okay, I forgot to say, sometimes refractive error can be, it can be induced within the critical period I talked about. Uh, let's say you have a child from the ages of 0 to 12, and mistakenly you prevent light or prevent one eye from actually seeing very clearly. Okay. The funny thing about the brain is that it hates blurriness. I don't know if I've made this comment before. The brain doesn't like images that are blur. So it will favor the one that gives it much clearer images over the one that will give it blur images. And in such people, we tend to see them having what we call a lazy eye, or what we locally call allochemy, where one eye has deviated from the normal position a little bit outward or a little bit inward, depending on the type of refractive error. Assuming one eye has a higher refractive error than the other, in that instance, the brain will prefer the eye that has the least refractive error and forget the other one. And once the crossover from the critical period, which is 0 to 12, which some doctors will say, okay, maybe 0 to 11. Once they cross over, there's nothing we can do about it unless maybe a surgical intervention or the use of presence, which is a different field on its own. I think maybe next time we will address binocular vision anomalies. So then that brings us to the fourth type of refractive error, which we call the presbyopia. So this one is more common in adults and is age related. Everybody will go through it. It starts from the ages of 40 and upwards. Okay. But there are cases where it does start earlier than 40. And in that case, we call that we call that person early presbyo. Okay. So if you recall, when we were talking about hyperopia, we said they make use of their accommodative system when it comes to near to see things afar clearly. So for a presbyo, this accommodative system that helps you to see things at near easily, the ability to do that diminishes. Okay. So there are proposed two reasons why that happens. One, either the muscles in the eyeball itself has lost the ability to contract, or the eyeball has the lens, as we're talking about, has taken in too much fluid, so contracting it has become much difficult. So we can assume the lens as an unshaken soft drink. When you're going old, then it's being shaken and there's more gas building up in it. So it becomes much difficult to press. Let's say if you want to press it, it becomes much difficult. And that's what happens in presbyopia. So for such people, when they come, they will say that, oh, I used to be able to read things close to me, but now, in order to see, I have to be shifting my hands a bit backwards. That's the only way I can still read my small Bible or the small text on my phone. Or I have to zoom in a little bit. Yeah, so once you see that you're having these kind of symptoms, then you should know that you're already at that age where you might need glasses. We also have people coming to the facility and say, oh, my parents never needed glasses. But I also ask them, is it all your parents that were reading? I don't think our great grandfathers, all of them knew how to read. So when it comes to near work, they didn't have much say in that. So uh, for a presbyo, their glasses is a bit different. I'm sure you've seen their glasses where you see there's a visible line at the bottom of the glasses. So that's just to say that the person has gotten to that age where they need a reading glasses to help them. But technology has advanced. We have ones you won't be able to see unless you wear it. Then you notice that there's a difference between the top part and the bottom part. We call those lenses a progressive lens. In case there are some parents interested in that, when you see your doctor, you can just let them know that, oh, you don't like the bifocal, you prefer the progressive, and they will make that one available to you. So the next slide. So the causes and risk factors and symptoms. So as I said, the causes, as you can see, the genetics plays a role. The axial length, as we discussed, either being too short or too long, can induce a refractive error. Sometimes the cornea also plays a role. That's the power we're talking about, the curvature of it. When it's too curved, it has too much power, or less curved, it has little power. Then also the environment, as we are talking about the development of the eye, the critical period. Kids who in their critical period are engaged on their phones a lot, or watching tablets a lot, or doing a lot of near work, they tend to develop myopia than kids who go outside to play during the critical period. So whilst they're playing, they're looking at things afar, which helps the eye to train itself to make things afar much clearer for the kid. So as we are discussing the symptoms, you have a bit of blurry vision, you have them squinting their eye, looking like how Chinese people's eye look. Sorry to use that word, but they'll reduce their eyelids to the point that it looks like a very thin slit. It helps with the vision, especially in myos. It really helps them to see much clearly. And they strain their eye a lot. They get fatigue. They get a lot of headache. Sometimes they might be having difficulties to see at night. And that one is a very tricky thing. Sometimes it might be due to refractive error, but it also can be due to vitamin A deficiency. So we call that night blindness if the person is deficient in vitamin A. And as you can see, Another cause is children using phones in their early childhood development, which studies have shown that it does induce myopia. So most of the developed countries are now switching from, they are not encouraging their kids to use their tablets and phones at their early childhood. They're encouraging them to go outside more to go and play. So please, the next slide. Okay, so how is diagnosed and corrected? So the simplest thing we can do at the facility is what we call the visual acuity test. Okay, so that one, you go, you sit down, they cover one of your eye, they ask you to read a chart which has the numbers or letters progressively decreasing in size. By each line, it decreases slightly in size. So for some kids, we have kids who are smart. They are very, very smart. So they might pretend that they are not seeing well. Okay, and that's when the refraction test come in, where we relax the eye and it gives us the eye true refractive error. And then you can truly tell whether the kid can see or can't see very well. Mm. So with that, we do the refraction, then we use either the retinoscope or the autorefractor, which just captures the total power of the eye, just like the retinoscope. Then we work with the values we get from it. Then we get them the necessary correction they need. Okay. So with the corrective uh, options, we can have contact lens, the spectacle, and there's a new emerging myopia control we call the auto K lenses. So what those does is that it's a kind of contact lens you wear at night before you sleep, and it shapes the cornea to make it less myopic, to make it less thick. So in that way, when you take it off in the following morning, your error improves a bit. You can see normally as a normal person is supposed to do, but uh, you need to talk with your doctor first to see if you're viable candidates for the auto K lenses. For very, very high myopia, I don't know if it will really work that well, but there are studies that show that yes, it does work. And we have low dose of atropine, where we instill the psychoplegic drug we call atropine. It lasts, once installed, the accommodative effect lasts about 7 days. That's for a drop of atropine on each eye. So we have, they come in dosage or let's say concentrations. So with low dosage concentration, when you install it in the child's eye, it has been shown to help improve the eye, make it less myopic. So as I said, it dilates the eye, meaning more light gets into the eye, and it helps them. I've not really read about it, but I know the studies have shown that it really does help. Okay, so please, the next slide. Oh yeah, and the surgical means there's what we call the refractive surgery. Sorry, I forgot about that one. So with that one, we use we use the laser to shape the cornea, just like how the auto K lenses are. But this is more of a permanent solution where we shape the cornea to make it uh, more normal than it is. But with the surgical means, honestly, when you get a good doctor, the results are very, very, very good. But sometimes the eye can go back to its normal state, or the refractive error can come back. And when it does happen that way, there's a tendency of it becoming worse than it was before. And then that means you have to go back again for them to give you that corrective surgery once again. Okay, so there is a uh, global increase in myopia. It's being felt in many, many countries, not just in Ghana. And it's because of the advent of phones and tablets, which we didn't have in previous years. So there are more and more kids having myopia, and it's no fault of theirs. Some, the genetics play a role. Some too is the early childhood development. That's also a major factor when it comes to that. So please, the next slide. Oh, okay. So I think with that we are done with discussing refractive error. So I'll be taking any questions. So initially, I wanted to start with uh, asking you guys to give me the questions you have about general about my refractive error. Then I'll answer them before going ahead with the presentation, but I forgot. So if you have any questions, then let me answer them, not just about the refractive error, even about anything you've heard about the eye you want clarification on. I will answer it.
Okay, so just as you heard Dr. Sam, he's open for any question whatsoever we may have in terms of general eye care. What's your question? Now is the time for us to have all of that. But thank you, Dr. Sam, for helping us to understand what refractive errors are, what it entails, the varying aspects that we have. One key takeaway for me was that, well, of late we tend to have lots of screen time, lots of gadgets. We are glued on our phones and our things. So then we tend to have all these things also having an effect on our eye, which I know I am one of the people who is currently suffering that. But all the same, there's always help for us. The earlier we catch it, the better it is for us. So let me know, what is the myth or the question that you have on eye, either the general eye care or even on the refractive error? The floor is yours. You can actually unmute. You can just put up your hand, you'll be asked to unmute, and then you go ahead, please. If not, and you'd like to type also, the floor is yours. If you would like to also share something that you've gathered, please, you can go ahead with that also. Do we have any questions, comments, concerns, anything about the eye that you would like to know, get to understand? Please go ahead with it. Okay, so as people tend to think about what they would like to ask and all that, I am just going to go on to, yes, this month is about the eye. And next month, we are also going to be talking about speech, language, and communication. I know we have dozens of parents who would like to get to understand the whole thing about speech, language, communication. We always tend to think communication is just the talk. What more is there to it? Our speech and language department is going to help us understand those other aspects of speech, language, and communication from next month. But for today, I would love to know what you've gathered. Let me check on our YouTube channel to see if anyone has written anything over there. Okay, so far I don't have any comments or concerns. So then it tells me that you've all understood it. Ha, good. And we do not, oh, I'm sorry, I nearly skipped Jail's question. Okay. So Jail says the explanation were great. My daughter was diagnosed of myopia recently. Oh, okay. Okay. So Jail, do you have any other comments or question or any other thing that you love to understand? This one, free consult. I'm not paying anything for it. But I'm glad you said the explanation was good, especially on the one that you've gotten. Okay. There's one from Esinam also. Esinam says I missed the explanation for why we will all experience presbyopia from age 40 if he can take it again. Okay, so Dr. Sam, we have
Okay, I get your question. So, with the presbyopia from the age of 40, as I was saying, we have a structure in the eye we call the lens and the muscles, the ciliary muscle. Okay, so these two structures play a role in the process we call the accommodative process. Okay, so by the age of 40, it's believed that the eyeball becomes too engorged with fluids. So you start developing some slight cataracts, that what we call the cataracts. So it becomes too engorged to the point that the muscles cannot compress it to help in the process of accommodation, or the muscles itself loses the ability to compress the lens to help in the process of accommodation when it comes to near. So in that sense, when it happens that way, the ability to do that near work becomes diminished. So the best way you can see things close to you is when you move it a bit further away from you. Since the further it away from you it is, the less effort of accommodation is involved. Okay, that's why when it goes back, you see it much clearly than when it's close to you. So when you come, we'll give you an additional lens, which we call the add power. Then that will help you to see the thing that's close to you much, much easily without engaging your eye too much. Please, was I able to explain it for you to understand?
SNM says thank you. I I remember going to Dr. Sam's office and he was asking me, no, he actually said you need to come back for a test. And yes, I'm confessing here. Dr. Sam, I'll come, okay. I was complaining to him that of late I can't tend to see the thing when it is closed and I have to move it back like that before I get to see what is written. And he says, when was the last time you tested your power? When this, when that, and a whole lot. So unfortunately, as we tend to age, a whole lot of other things tends to also come in. But yes, we need to go. So Dr. Sam, how often should one see an optometrist in a year?
Okay, so in a year, we recommend at least twice a year. So you
Mm,
can space it out how you want it, but twice a year, just for a routine eye checkup, just to make sure everything is fine. Uh-huh.
okay, okay. So just go in randomly twice a year. Okay, let's find out from Jill. Please go ahead. You've been asked to unmute.
So I just have one more question. So when we took my daughter to the hospital, the optometrist was trying to explain to me that something was elongating in her eye, and they had to give her some kind of special lens to streamline to for her to get half focus. So she used the lens for about 1 year, and we went back again and he said, "Oh, only one eye has corrected. We have to change it again." And these are really very expensive lenses. So I didn't really understand the elongating part thing he was saying about something elongating inside her eyes. I didn't understand that part. Maybe the doctor will explain.
So, Dr. Sam, what is the elongation? What is it? And
Okay, so you if you remember what we were talking initially, we were talking about axial length. I'm assuming that's what he was referring to, that the eyeball is becoming much longer than it's supposed to be. If your child is between the critical period, once it's caught, we can reverse what is going on.
oh,
And so
okay.
that's why he said one eye has corrected, but the other one is still being worked upon. So you have to change the power. Because after the critical period, whatever is there is stuck now. There's nothing you can do about it. So I think if it's the axial length he's talking about, then I think he's correcting the refractive error due to the axial length being longer than normal. I hope that was enough to answer your question.
Yes, please. Thank you.
You're welcome.
Okay. So then it means we need to be changing the lenses as and when the need arises?
Yes, please. So when you see the doctor, he does the test again and he sees that there's a difference between the old one and the new one. He would ask you to change it in order to meet the demand you need now
Okay.
compared to then.
And how often should that be checked? Or you can go check
So
at it?
for a normal person, you can change your glasses every 2 years. But for special cases where we know that the refractive error is very high, or in children like that, we might give them a year or 6 months, depending on the doctor who is seeing the child. Some will say, oh, let them use it for 6 months. Let's come and recheck and see if there's any changes or any improvement in it. Some will say, go use it for 1 year, come back and let's see if there's any improvement or change in it. So in that way, they can see or pick up something earlier than waiting 2 years, then it's already worse than it's supposed to be.
Okay. So then it would depend on the condition and then
Yes,
the need
the
that one.
person demands and the doctor who is attending to the patient.
Okay. All right. So at least that helps us in understanding. I have asked my own. Do you also have any that you would like to ask? If you would want to type it, I am ready to read it out. If not, okay. Eunice also mentioned or was saying a thank you for the presentation. I'm glad when people get to understand all the things that we do at a particular point in time. I'm grateful. Okay. So, as earlier mentioned, we do this on the fourth Sunday of every month. So, in every month, well, with the exception of November and December, we tend to have our monthly webinars, which has to do with our Parent Professional Connect. So we pick a topic and then we discuss it. And we are grateful that you've been able to join us from January right on to this month in August, where we are discussing the refractive error in terms of our eye, what we need to do. And as we've all learned or heard, we are supposed to be going to the optometrist to check our sights at least twice in a year. So please, let's make that effort. Let's ensure that we take good care of our eyesight, because with this, when we lose it, there is no replacement anywhere. So let's do what we need to do. And next month, as earlier mentioned too, we would be having our speech, language, and communication department helping us to understand a number of things. So please do make a date with us. And when the flyer comes out also, kindly share it with others so they also get to be a part of it. We are grateful that you made the time to join us, whether you joined us here on Zoom or you joined us on YouTube. And for those who do not know, our channel, Parent Professional Connect on YouTube, has a lot of webinars we've had over the years. So please share the link with others. Help others also get to learn something out of it. That is the purpose for having this particular program. We want to be able to bring our professional to you, our audiences. So together, we all get to learn something. We all get to acquire some knowledge, and we all get to improve on the things that we need to improve upon. Thank you once again for making the time to be with us. We are grateful that you've taken some time off your day, because we know it's not easy, especially on a Sunday evening where you would like to relax, but you made the time. Thank you so much for being a part of it. Do remember next month's own. And Dr. Sam, we are grateful to you also for joining us once again. I know I can always count on you. I'll come and disturb you so
Thank you. Okay.
much. So thank you, everybody. Please have an awesome week and all the best to everyone.
You too.
Bye.
Bye. Bye.